Welcome back. In this final eyepiece, we will start off with some prognosis. Prognosis of BRAO varies depending on the severity and the specific case. Retinal pallor fades and the circulation is restored over a few weeks typically. The prognosis is good if the fovea, or the part of the retina responsible for central vision, is spared. 80% maintain a vision of 20 or 40 or higher, or better, I should say. Most do have a degree of permanent visual field loss. 10% risk of BRAO occurring in the fellow eye is present. The Hollenhorst plaque was one of the items on the list that can cause BRAO. This can also be seen in carotid artery disease. Carotid artery disease is an occlusion of the carotid artery, and this is caused by accumulation of the low-density lipoprotein in the internal carotid artery. The accumulation then can form plaques on the artery wall. Several risk factors that can raise the likelihood of plaque formation is hypertension, smoking, diabetes, and family history of the plaque and the arteriosclerosis. Age, older the patient is, the more likely they will develop carotid artery disease, as well as obesity. The arteriosclerotic process narrows and stiffens the internal carotid artery, and because of the loss of the natural elasticity of the vasculature, it is easier to clog and form plaques on its wall. The plaques decrease the blood flow because it stenoses the carotid artery, and therefore there is not as much blood flow that's going to the head and the eyes. To compensate for that, the blood flow is going to increase, and that's going to increase the chance of plaques rupturing. This triggers a clotting cascade, and some of the plaques can even break off and circulate into the eye, causing BRAO. So carotid artery disease and the BRAO can go together. So to know more about carotid artery disease, patients with CAD can experience the trouble seeing because of the BRAO, numbness or weakness in the face or limbs as some of the clot enter the brain. They can have headaches with increased intracranial pressure, difficulty speaking, and also dizziness. This doesn't mean that everyone with carotid artery disease will experience all these symptoms, but the characteristic is that these symptoms have sudden onset with this disease. So the important component of investigation and treatment of CAD would be thorough history and physical exam. You should ask the patient about headaches and his family history of stroke, atherosclerosis, and heart disease. Not to mention, because we learned throughout this presentation, it would never hurt to do a fundoscopy and also test the muscle strength to see if they have any limb weakness. You should regularly talk to the patient and look for signs of incoherent speech and comprehension, and also listen to the neck with your stethoscope for carotid bruit. If suspicious for carotid artery disease, we should perform a CT angiography head and neck. For treatment, if the patient has had a stroke, it's a good idea to assess for carotid endarterectomy, which is a surgical procedure to remove the clot that's causing all the symptoms. And in the long term, there is a mainly pharmacological approach. Antiplatelet therapy that includes aspirin 300 milligrams per once a day for 2 weeks, and after which you switch to clopidogrel, 75 milligrams once a day. We can also initiate statin therapy to hopefully decrease the amount of LDL in the blood, and also maintain hypertension and diabetes aggressively. So a strict control of the blood glucose level as well as the blood pressure. That was a lot of information. We covered BRAO and the carotid artery disease. Here's a summary chart of everything that we covered today. This is a reference of all the resources that we've used for this presentation. Thank you for watching.